Hello, everybody, and welcome to another episode of Mind Matters, Navigating Head Injuries and Concussions. And today I'm joined again by Dr. Erik Reis with the Neural Connection. Today he's joining us for part 2 of our discussion. I hope you caught last week's episode. Dr. Reis, how's it going?
Yeah, it's going really well. Thanks, Kylie. I'm really excited to be here. So thank you guys for having me again.
One of the things you talked about, that BPPV and a couple of other disorders. Now, some of our patients or clients may not know that we have a brain injury, but those things don't necessarily come from an injured brain per se, right? We're
Correct.
talking about potential inner ear vestibular disorders. Can you kind of differentiate on some of that, where some of these things may be coming from?
Yeah, great question. I mean, you can get BPPV without a brain injury. That's a very accurate statement. I weirdly have seen so many cases of females who are dealing with hypothyroid issues or Hashimoto's, an autoimmune thyroid condition, where they'll come in with this persistent BPPV, this persistent vertigo, this rapid onset vertigo that leaves and gets alleviated with Epley maneuvers. And the crystals just continuously come back and they come back and they come back. And so you clear the crystal, they're good for a little bit. You clear the crystal again, you see these things ebb and flow. And so with the metabolic workups that we're doing, we're seeing a lot of thyroid complications as a result of that. Now, underlying inflammation, gut inflammation, brain inflammation, these things kind of go hand in hand a bit, but it's such an interesting pattern. And so you can get BPPV for an array of reasons. Some people, my understanding is that there's not one genetic marker, but some just maybe are just more predisposed than others. It could be anatomical issues, or it can be just the fact that you have some rapid onset inflammatory responses that occur and crystals get kicked out. I don't think we still fully know the full story, but we know, John Epley was the pioneer with the Epley maneuver to figure out how to clear these crystals and alleviate those symptoms. And so BPPV is a condition. It's benign, so it's not something that's gonna, completely take you out. It's just it's a horribly debilitating condition in the moment. And these are the patients that usually come in saying, listen, every time I turn my head to the right when I'm laying in bed, or anytime I move to grab something off the shelf, I immediately feel like my world is moving and I get this onset of vertigo. But it only lasts for like 5, 10, 15 seconds and then it goes away. So they'll come in and they say, listen, I know what triggers my stuff, so I don't do it. So I don't turn to the right anymore. Or I don't reach up for that or ask my husband or wife to do it for me. And so those are pretty common things I'll hear in the history. What you're dealing with is your inner ear system, which traditionally speaking would be known as your balance systems or your vestibular system. We know that these systems really do help with our ability to navigate ourselves in relationship with gravity. So the example I use with patients is, listen, if I threw you in an elevator and I shot you up 20 stories, you'd know that you were moving in some way, shape, or form, but you don't have to be physically moving to feel that. Your change in gravity, or these systems that are graviceptive, we say, will tell you that you're moving. It's the same thing of you being in a car. So Kylie, if you and I were driving in a car and your eyes were closed and you weren't moving your neck and you weren't doing anything, but I was driving down the road, you'd feel that translational movement. So that's part of the inner ear system. That's the otolithic system. You have two different aspects, and I won't go into too much detail, but your inner ear system is really important because it does help with balance and stability. We also know now that these inner ear components have cognitive aspects. We know that these inner ear systems also regulate parts of your autonomic system as well. So of course, that makes sense. If you're in a dizzy spell, your heart rate's probably going to go up. You're going to have a bit of a sympathetic response or a stress response, because that's an appropriate response for your brain to kind of have this what's going on kind of perspective. So this inner ear sits kind of in the back of your skull back here, right where your mastoid bone is. In a lot of conditions and situations, like I said, most vertigos are either crystal induced or they're centrally maintained. And once you kind of figure out that pathway, you can usually treat it and rehabilitate it with eyes, inner ear balance mechanisms. The neck will always play a role in that feedback as well. It just depends on the patient and what they need in front of you to take care of that.
Man, that's fascinating. Yeah, I could definitely hear you talk about it all day long. I don't know necessarily what to talk about it, but it certainly is fascinating. Just another thing, you mentioned the neck right there. So I do want to kind of dive into some of that. We see a lot of, in our clients here, cervical instability, so whiplash, right?
Yeah.
And then we've been talking about concussion symptoms, mental health outcomes. Those are tough to quantify, right?
Yeah.
So how do you go about, what's your approach with some of those kind of invisible issues, we'll say.
Yeah. Honestly, I still feel once again as though I'm still trying to figure that out. I think I'm very much along the lines of until proven otherwise, I'm going to make the assumption that patients are dealing with some of these things, and I'm going to really do my due diligence with my assessment. If I have any hesitation or any question, whether I'm treating somebody for a little bit or on the initial assessment, anytime when they tell me specific aspects of their history. So, for instance, if I have a patient coming to me and they just say, my head just feels like I can't control it, it's unstable, it hurts, it's just kind of in a situation where everything feels like loose, right?
Mm-hmm.
Very different than somebody coming to say, listen, my neck is super tight and rock hard, and I had this counter coup whiplash injury. That's a different conversation, right? So if I suspect cervical instability, I will not hesitate to shoot x-rays and do flexion extension films. I will send them out immediately for that. It's a low-hanging fruit. It's an easy diagnostic to run, and it's a great entry point for me as a clinician to understand whether or not I need to investigate that even further. Because if they have proper cervical instability, they don't belong in my office, right? So those are the patients that don't need soft tissue. They don't need any sort of dry needling. They don't need any physiotherapies. They definitely don't need chiropractic adjustments, right? Like those are contraindicated for that patient.
Right.
That patient most likely needs some form of intervention, and whether it is a surgical intervention, whether it's stabilizing the head and the neck, there's
Right.
probably other things that they need before they come see me. Because this is the kicker with all of that. Your neck is a massive input into the brain. And so I think I've said this analogy before, but the metaphor that I give patients is if you have three friends that go to the same party, you expect them to tell you the same story, and they kind of have to, right? So everyone's like, yep, I get that. The time, the place, what was there, all those things. Three major players for you, the three friends for you after an auto injury or a concussion or a TBI is one, your neck, some muscles and joints of the entire body, but especially the head and the neck. Friend number two is your eyes. And then friend number three is that inner ear vestibular system. If friend number one is not telling your brain the right information, and let's say theoretically the eyes are good and the inner ear system is good, then your neck is the biggest problem. And your neck is constantly telling the brain wrong information.
Yeah.
So therefore the eyes and the inner ear are inherently going to be negatively affected because of that. Even if I do all the visual and all the vestibular rehab with that patient, if the neck is unstable or the neck is no longer giving the appropriate input, or if it's deafferentated and it's not giving as much input as it was before, then I'm never going to get that patient better. And so I have to understand the fundamentals of what that encounters and what that entails. And I have to make sure that we approach that treatment paradigm as quickly as possible. Because cervical instability could potentially lead to cord damage. It could lead to bigger issues down the line that we want to stay away from as fast as possible. So if I suspect any cervical instability, I will refer them out for films immediately. It's an easy, quick diagnostic. And then at that point, we make the clinical decision. And then after that, I'll go on and I'll look into other treatment paradigms. But I unfortunately have seen cases where cervical instability was not investigated and that patient suffered for days, weeks, months, and years. I've also seen cases where patients did get the cervical instability addressed and it made a significant difference in their outcomes. But if you don't look for it, once again, you'll never find it. And I think that that's probably the bigger part of the message.
I'm so glad you touched on that, Dr. Reis. Here at Shane Smith Law, a lot of our clients come to us with multiple injuries, right? They've been in horrendous car accidents, or some have been hit by cars, or you name it. We see a lot of different clients. So multiple injuries, and anytime, we get a client in a situation like that, they've got a neck injury, back injury, shoulder, elbow, both knees are messed up, there's a finite amount of resources to deal with. I always look at it as a prioritizing the injury situation. And I always try to encourage our attorneys and case management team to make sure our clients understand the critical importance it is to treat that neck and that back. If nothing else, put those at the top of the list, treat everything else, Mr. Kim, but we've got to get that neck under control.
Well, and I'm grateful to hear that, Kylie. I think you have such a good head on your shoulders for clinically what, the paradigm should look like. And your clients are so fortunate to have you in their back pocket to be able to advise that, because I think one of the hardest things for me clinically with coming in and having new patients is there's so much of an educational curve that needs to occur to educate patients about what they should look for, what they should know. Because no patient that has ever walked in my door has ever taken a class on how to be a patient. And as fundamentally silly as that sounds, it's just the reality of it. And so that's a really big component, is setting the table, making sure expectations are appropriately put up in front, and then making sure that they understand the process with that. So it's good to hear that there are other people out there doing that.
Oh, absolutely. Yeah, it is a mission of mine. So yeah, for sure.
Good. Well, I like that. I think you're accomplishing that mission on a daily basis there, sir. Well done.
One other thing, when you're talking about neck injuries, you started to touch on it. Neck injuries can manifest to a lot of other issues and areas other than the neck. So necks can lead to. I want you to kind of dig into how that touches on maybe headaches or even TMJ, for example, that sort of thing. Can you touch on that?
Yeah, well, look at it this way. Everything's connected, right? So when you get an injury to the head or the neck, you're going to inherently have problems with other structural aspects or other areas, depending on how the injury occurred, pre-existing conditions, and things like that. Like, there's going to be outcomes with that. And so this whole trigeminal system of the face. So this trigeminal system is a specific cranial nerve. It's your fifth cranial nerve for the fellow nerds out there. But for those of you who are dealing with symptoms, it's really when you get pain, like in the face or the sides of the head. People who get migraines, this is really hits home for them, right? So when you get that stabbing, shooting pain over the eye or over the temple, that's the trigeminal system that's inflamed and very upset with you. And so when you have these injuries, when you have these neural networks that become unstable, what happens is you not only alter blood flow, but you have this inflammatory cascade that occurs. You have neurons that are inherently disrupted, damaged, or broken, or they die off. And you essentially have changes in blood flow and oxygenation. So what's interesting with this, and with TBIs, and this is some of the research that's come out over the last couple of years, is if you, let's say theoretically, you're like trying to activate your right frontal lobe. So like if you like move your left hand doing something, if I grab a cup of coffee, my right frontal lobe will light up. Blood flow is usually coupled with neurological function. So like in an MRI, this is how MRIs work. You'll see more blood flow in an area where there's more neurological activity. We like that. That's a really good thing. After a concussion or a brain injury, what'll happen is you'll have this neurological activity going on, let's say in my right frontal lobe again, but you'll actually see decreases in blood flow and oxygenation. And that's not a good thing, because that's something that's so vital for function for nerves, but now you're not able to clear out the trash. You can't take out metabolites. You're not getting nutrients to the area. You're not getting oxygen. And those are really pivotal factors. And so you see these changes, and that's why there has been a lot of new research showing, the earlier you can get somebody to do like just basic low-grade cardiovascular exercise using kind of the Buffalo concussion treadmill test, the protocols for those, the faster you're going to get people back in action, because you're optimizing blood flow to the brain and body. So the neck is a vulnerable area. I think we all kind of would agree on that. But what happens is the brain kind of twists and shears and rotates on itself with a whiplash, a concussion, or massive TBI, depending on the TBI. So you also have inherently these other areas of the brain become affected. So yes, it can be the TMJ. Yes, it can be blood flow. But what controls blood flow? It's these autonomic pathways, these automatic pathways in the background that we don't have to think about, but they're really important for us. So, I haven't thought once today about getting enough blood flow to my fingers, my toes, and my brain, but my brain has taken care of that for me. I haven't thought about digesting the food that I ate for lunch today. I haven't thought about getting enough blood flow to those tissues. I haven't thought anything about regulating my heart rate, but my autonomic nervous system takes care of that for me. Yes. What happens after a big injury to the head or to the body with a TBI or concussion is those automatic processes in the background get altered and they get affected. So these are the patients that come and they're like, I got in a car accident and my neck hurts and I'm dizzy and I feel off, but my stomach feels weird. Or I'm getting heartburn now, and I've never had heartburn before. Or they're like, I feel a bit constipated over the last couple of months. That's an autonomic outcome that we know pathophysiologically is relatively well documented. But once again, if you don't ask those patients about it, you're going to miss it. And so patients will go see the gastroenterologist, they go see the primary care doctor, they'll get these things managed, but no one's cueing it back to the fact that they injured the brain, which controls all of those low-grade centers and activities already. And so that's something that I'm picking up a lot on with patients. A lot of patients coming in with acid reflux, changes in digestion, feeling like they're gassy and bloating after eating meals that they had no problems eating before. So that's also the same things that control blood flow and oxygen. So if you're not looking for that as a provider, you should be. If you're a client or if you're a patient, don't be scared to talk about that stuff after the injury as well, because it's relevant to your case most likely.
That's a great point, and I'm glad you brought that up. You've mentioned the autonomic nervous system a couple of times. And its effect on our bodies especially after something like a car accident, even the sympathetic nervous system. So you're talking just basic functions, things you don't think about. That is another fascinating. We could probably do a whole nother show on that stuff. I would love to kind of hear you break that down, because
happy to.
Deep waters right there. Then you're talking about, well, we talked earlier about how, other doctors should be involved with, with caring for patients in such dire straits, right? And a lot of them are going to be on pain medicines, for example.
Yep.
So you throw opioids in the mix, and that's going to slow down, gastric motility. I mean, talk about some of the complicating factors when you're mixing disciplines and care approaches. And I'd love to hear your thoughts on that.
That's where communication is huge, right? So especially now today with, there's a significant amount of the population now that are on like GLP-1 agonists, right? So newsflash, we all produce GLP-1. It's a peptide that my gut produces, and so does Kylie's when we're not taking Wegovy and semaglutide or any of those factors. But those things can play a role as well too, because they feed back to the hypothalamus. They feed back to this area of the brain that's responsible for, kind of being our thermostat for a lot of different basic functions we don't really think about. It also changes, like you said, gastric emptying. So it slows down how quickly food is thrown into the small intestine. And that's a great thing for us if you're trying to lose weight, if you want to digest your food, things along those lines. But it can complicate things as well, because what if it slows it down too much, to the point now where food is fermenting in the stomach or the small intestine? You lose the gastric and the small intestinal motility. Now you have dysbiosis. Maybe you have these other issues. Maybe you have a predisposition for like small intestinal bacterial overgrowth. You can kind of see how the cascade goes. And so for me, once again, it comes down to communication. I'm not scared to pick up a phone and call another doc. I don't think other doctors should either, because it should be for the better of the patient. And so it all comes down to making sure that you set the table in the beginning, and that when those conversations arise, you get to the bottom of it as quickly as possible to help the patient.
All right, everybody, that's going to do it for another episode of Mind Matters, Navigating Head Injuries and Concussions. Again, I want to thank Dr. Erik Reis from the Neural Connection for joining us on set today to give us some of his passion and expertise with all things brain injury. I hope our audience has enjoyed our discussion as much as I have. Please don't forget to hit that like button and subscribe to our channel to keep up with our content, and leave us a comment and let us know what you thought of today's episode. And as always, remember, if you're in pain, call Shane at 980-999-9999. Take care.
In pain, so I call Shane. 980-999-9999. In pain, call Shane.